Welcome to the Deep Dive, your shortcut to being well informed. Today we're diving into something that, well, affects all of us, our skin. It's our body's biggest organ, right? Our first line of defense. And it's incredibly complex. We often don't really think about it much until something goes wrong. So we're taking a closer look today at dermatological disorders, the conditions, and importantly, the drugs used to treat them. We've pulled the key insights from an expert presentation by Dr. Kyle Hassan.
That's right. And our goal here isn't just, reciting lists of drugs or conditions. It's about understanding why these things happen. How do these treatments actually work deep down? And what are the really critical things you need to think about when managing skin health? You'll definitely walk away with a much clearer picture of conditions like acne, psoriasis, and eczema, a real shortcut to being informed.
Okay, sounds good. Let's unpack this then. Maybe start with a quick primer on the skin itself, just the basics. So it's got two main layers, right? You've got the epidermis on top that's mainly made of these tough protective cells, keratinocytes.
And then underneath that, you have the dermis. That's the thicker layer. It's packed with stuff, sweat glands, sebaceous glands making oil, hair follicles, blood vessels. It's busy down there.
Right, it's not just a simple covering. And these layers, they do a lot for us. I mean, protection is the big one, isn't it? Against chemicals, germs, UV light.
Absolutely. Protection is key. But also wound repair, sensation, touch, temperature regulating body heat, even making vitamin D.
It really is a multitasking marvel.
It is. And when those functions get disrupted, that's where skin disorders come in. We can kind of group them into three broad types. There are infectious ones caused by bacteria, viruses, fungi, parasites.
Like boils or cold sores.
Exactly. Boils, impetigo, ringworm, athlete's foot, cold sores, chicken pox, even things like lice or mites, those are all infectious. Then you have inflammatory conditions where the immune system is kind of overreacting. And finally, neoplastic disorders, that's where you get abnormal cell growth, sometimes leading to tumors. Understanding these categories helps frame why certain treatments are used.
Got it. Okay, let's dive into one almost everyone knows something about. Acne vulgaris. We're talking more than just a few spots here, right? It's a chronic thing for many people. You see blackheads, whiteheads, pustules, papules, sometimes even scarring.
Yes, it's very common.
And what's really interesting is that there seem to be four main factors driving it.
That's the crucial part. Four key things usually happening together. First, increased sebum production. Your skin makes more oil, often influenced by genetics and hormones.
Okay, more oil.
Second, follicular hyperkeratinization. It's a bit of a mouthful, but basically the cells lining your pores don't shed properly. They get sticky, build up, and clog the pore, like a blocked drain.
Right, setting the stage.
Third, there's a bacterium, Propionibacterium acnes, or P. acnes. It loves those clogged, oily pores and multiplies.
And that leads to the fourth factor.
Exactly, an inflammatory reaction. The body reacts to the bacteria in the blocked pore, causing redness, swelling, and pain.
So it's this combination of oil, blockage, bacteria, and inflammation.
Precisely. And because it's complex, the treatment needs to be strategic. It's chronic, so you often need early, aggressive treatment. And using combination therapy, hitting multiple factors at once, tends to work best.
Makes sense. So the goals are, what? Less oil, unclog pores, kill bacteria, reduce inflammation?
You got it. Reduce sebum, normalize that keratinization, target P. acnes, and calm the inflammation. Typically for mild or moderate acne, we start with topicals, creams, gels, lotions. For moderate to severe cases, we often need systemic treatments, meaning pills.
Okay, let's talk topicals then. Benzoyl peroxide, that's a common one, right? Even over the counter.
It is, and it's often first line for mild to moderate acne. It's got a great dual action. It kills P. acnes, it's bactericidal, and it helps open up pores. It even mildly reduces sebum.
So it tackles two, maybe three of those factors.
Right, which is why it's effective. It can be drying or irritating for some people, causing peeling, but it works well.
What about salicylic acid? I see that everywhere too.
Salicylic acid is mainly an exfoliant. It helps clear out those blocked pores, the comedones. It's often a good option if someone finds retinoids, which we'll get to, too irritating. It also has some mild anti-inflammatory effects.
Okay. Any others in this group?
Yeah, there's azelaic acid. It's good for mild to moderate inflammatory acne. It has antibacterial, anti-inflammatory, and some pore opening effects. And dapsone gel, brand name Axone, that's another option, known for its antibacterial and anti-inflammatory properties. Sometimes useful if others cause too much irritation.
Got it. Now, you mentioned retinoids. Those sound important.
Oh, definitely. Retinoids are a major class of drugs. They're derivatives of vitamin A. And what's fascinating is how versatile they are. We use them for acne, sure, but also wrinkles, psoriasis, dark spots.
How do they work?
They actually work at the genetic level. They bind to specific receptors in skin cells and regulate gene expression. Basically, they tell the skin cells to behave more normally. It's quite sophisticated.
Wow. So for acne, what do they do specifically?
They hit almost all the bases. They significantly reduce sebum production. They stop pores from clogging, reducing comedogenic. They decrease the P. acnes population. They have strong anti-inflammatory effects. And they normalize that hyperkeratinization.
That sounds incredibly effective.
They are. We talk about different generations, first gen like tretinoin, third gen like adapalene and tazarotene. Even a newer fourth gen trifarotene, usually apply them at night, but there are downsides.
The side effects.
Yes. Irritation, dryness, peeling, these are common, especially at first. And importantly, photosensitivity. You must use sunscreen with retinoids.
Okay, sunscreen is crucial.
And then there's the oral retinoid, isotretinoin, often known by brand names like Accutane, though that specific brand isn't marketed anymore. This one is extremely effective for severe scarring acne that hasn't responded to other treatments, but it comes with serious warning.
The black box warning.
Exactly. Isotretinoin has a black box warning because it is absolutely contraindicated in pregnancy. The risk of severe birth defects is incredibly high. So, strip contraception is mandatory for female patients, often requiring enrollment in specific risk management programs like IPL-DIG in the U.S.
That's incredibly serious.
It is, and there have also been rare but serious reports linking it to depression and suicidal thoughts. It really brings up that critical balance for you, the listener, to consider powerful effectiveness versus potentially severe risks. It's a conversation that needs to happen between patient and doctor.
Absolutely. Those warnings really drive home the potency and the need for extreme caution and monitoring.
So besides topicals and isotretinoin, what about other systemic options for acne? Pills.
Yeah, for moderate to severe inflammatory acne, oral antibiotics are commonly used, things like minocycline and doxycycline. They primarily target P. acnes bacteria and also have anti-inflammatory effects.
For some women, hormonal agents can be very helpful. Certain oral contraceptives have anti-androgenic effects, meaning they lower the male hormones that drive sebum production. Spironolactone is another drug with anti-androgen effects, sometimes used off-label for women with acne.
Off-label meaning not specifically FDA approved for acne, but known to work.
Correct. And more recently, there's a topical androgen receptor inhibitor called clascoterone, or Winlevi. It's approved for patients 12 and up, so it offers a way to target hormones locally right on the skin.
Interesting. Lots of different angles to tackle acne. Okay, let's switch gears now. How about psoriasis?
Right, psoriasis, this is another chronic inflammatory skin condition. Affects maybe 1–2% of people. It typically shows up as these well-defined red plaques covered with silvery scales.
And what causes that?
It's essentially skin cells growing way too fast, epidermal hyperproliferation. And the underlying cause involves a mix of genetic predisposition and an autoimmune response. Specifically, T cells in the immune system mistakenly attack healthy skin cells, triggering inflammation and that rapid cell turnover.
So the immune system is the culprit here. How do you approach treatment?
It's usually tiered. For mild disease, we often start with topical treatments. If the disease is more severe, or if topicals and maybe phototherapy aren't enough, then we move to systemic treatments.
Let's look at those topicals first. What's typically used?
Topical corticosteroids are the mainstay, the first thing we usually try. They're effective, relatively inexpensive, and generally safe when used correctly. They work by reducing inflammation and slowing down that cell growth.
You mentioned potency before with acne treatments. Is that important here too?
Absolutely critical. Corticosteroids range from low potency, like hydrocortisone, to super potent, like clobetasol. You'd use a super potent one, say class I, clobetasol propionate at 0.05%, for really thick plaques on elbows, knees, maybe hands or feet. But you would never use that on the face, groin, or armpits areas with thinner skin. There, you'd use much lower potency to avoid side effects like skin thinning.
Right, using the right strength in the right place. What else is used topically?
Calcipotriene is another key one. It's a synthetic form of vitamin D3. It works by inhibiting that rapid keratinocyte proliferation and helping cells differentiate more normally.
Oh.
There's also tazarotene, which we mentioned is a retinoid. It's a first-line topical for plaque psoriasis, too. And salicylic acid can be helpful, especially for scalp psoriasis in shampoos, to lift and remove the thick scales. It can also help other topicals penetrate better.
Any downsides to salicylic acid?
Well, it shouldn't be used on large areas of the body, especially in children, because there's a risk of systemic absorption and toxicity. Oh, and there's coal tar. It's an older treatment, keratolytic, maybe some anti-inflammatory effect,
Okay.
but honestly, it's not used much anymore. Limited efficacy, it smells bad, stains clothes, can be irritating.
Doesn't sound ideal.
Not really.
So if topicals aren't cutting it, what's next? You mentioned phototherapy.
Yes, phototherapy. Using controlled doses of ultraviolet light, either UVA or UVB, sometimes with a photosensitizing drug called Sorolin, that's PUVA therapy. It can be very effective, but requires visits to a clinic and, crucially, eye protection.
And if even that doesn't work, or for very severe cases?
And we move to systemic therapies. These are medications taken orally or by injection, and they generally have a higher potential for adverse effects, so they're reserved for more severe resistant disease.
Like what?
Methotrexate is probably the most frequently prescribed systemic drug for psoriasis. It's an immunosuppressant. Acitretin, brand name Soriatane, is an oral retinoid, second generation, used for severe resistant psoriasis. But really important here, acitretin is pregnancy category X, absolutely cannot be used during pregnancy, and patients must strictly avoid alcohol while taking it and for some time after stopping.
Another serious warning there.
Definitely. There's also apribulast, or Otezla. That's an oral drug that inhibits an enzyme called phosphodiesterase 4, or PDE4, which is involved in inflammation.
Okay. And then the biologics, these sound like the cutting edge.
They really are. Biologic agents have revolutionized the treatment of moderate to severe psoriasis. These are proteins, usually antibodies, made using DNA recombination technology. They're given by injection or infusion.
And the big deal is how they work, right? You said they're targeted.
Exactly. If we connect this to the bigger picture, unlike older systemic drugs that broadly suppress the immune system, biologics are designed to block very specific molecules involved in the inflammatory process of psoriasis.
Like what specific molecules?
Well, some are TNF-alpha blockers. TNF-alpha is a major inflammatory cytokine. Drugs like adalimumab, Humira, etanercept, Enbrel, infliximab, Remicade block it.
Okay.
Others are interleukin inhibitors. Interleukins are signaling molecules between immune cells. So some drugs target IL-12 and IL-23, like ustekinumab, Stelara. Others target IL-17A, like secukinumab, Cosentyx. And newer ones specifically target IL-23, like guselkumab, Tremfya, and risankizumab, Skyrizi.
Wow, that's incredibly specific, hitting just one part of the inflammatory cascade.
Precisely. That specificity is the leap forward. It generally means better efficacy for many patients and often a different, sometimes more manageable side effect profile compared to broader immunosuppressants, though they still require careful monitoring, especially for infections.
That targeted approach is really impressive. It makes sense why they'd be reserved for more severe cases, though, given their complex therapies.
Yes, they represent a significant advance, but also come with considerations like cost, administration by injection, and the need for ongoing monitoring.
Understood. Okay, let's tackle our third main condition, atopic dermatitis, or AD. Most people probably know it as eczema.
Right, AD or eczema. Another chronic skin disorder characterized by inflammation and really intense itching pruritus.
And there's often a link to other conditions.
Yes, it's often associated with what's called the atopic triad, asthma, and allergic rhinitis, hay fever. You might see these conditions in the same person or within the same family. It suggests a combination of genetic factors affecting the skin barrier and immune response, plus environmental triggers.
And it often starts young.
Very often. It frequently presents in infants and young children, and because the skin barrier is compromised and there's a lot of scratching, secondary bacterial infections, often with Staph aureus, are really common.
So managing that itch must be key. How do you approach treatment?
Absolutely. Managing the itch-scratch cycle is crucial. And before even talking about drugs, non-pharmacologic management is foundational. It's incredibly important.
What does that involve?
A lot of practical things you can do. First, identifying and avoiding triggers. That could be specific allergens, certain foods, harsh soaps or detergents, rough fabrics like wool, even extremes in temperature or low humidity.
Okay, avoidance first.
Then, intensive skincare. Frequent use of moisturizers, emollients, to repair and protect the skin barrier. Taking lukewarm baths, not hot ones. Using gentle, non-soap, fragrance-free cleansers. Wet wrap therapy can be very helpful during flare-ups to hydrate the skin and reduce itching. Keeping fingernails short is simple but important. Wearing soft cotton clothing.
Makes sense. Anything else?
Sometimes, a sedating oral antihistamine at night can help reduce scratching during sleep, though they don't treat the underlying inflammation, but breaking that scratch cycle is vital.
So really focusing on barrier repair and avoiding triggers. That sounds essential.
It really is. You can't underestimate the importance of these basic measures.
Okay, then what about pharmacologic treatments when those steps aren't enough?
Again, topical corticosteroids, TCS, are the first-line treatment for flare-ups. They reduce inflammation and itching.
And potency matters here too, I assume.
Definitely. General rule, use the lowest effective potency. Low potency, like hydrocortisone 1%, is usually recommended for the face, groin, armpits, and for infants, or for long-term maintenance on sensitive areas. Medium potency, like betamethasone valerate 0.1%, might be used for the body. High-potency agents are usually reserved for short-term treatment of severe flares on thicker skin areas.
And the same warnings apply about overuse, especially potent ones on thin skin.
Exactly. We always worry about local side effects like skin thinning, atrophy, stretch marks, striae, and also potential systemic absorption, especially with potent steroids over large areas or in children, which could lead to HPA axis suppression or even growth retardation.
So careful use is key. What if steroids aren't suitable or aren't working well enough?
Then we have the topical calcineurin inhibitors, or TCIs. These are tacrolimus ointment, Protopic, and pimicrolimus cream, Elidel. They are immunomodulators, meaning they modify the immune response. They specifically inhibit the activation of T cells and mast cells in the skin, reducing inflammation and itch. They're approved for adults and children over 2 years old.
Are they a good alternative then?
They can be, especially for sensitive areas like the face or eyelids where long-term steroid use is problematic. However, this raises an important point.
Another warning.
Yes, both carry an FDA black box warning regarding a potential, though not definitively proven, risk of skin cancer and lymphoma with long-term use. It's something that needs careful consideration and discussion.
Okay, another significant point for patients to be aware of. This field really seems to be advancing, though. Are there newer options, too?
Yes, this is where it gets really interesting, with more targeted therapies emerging for AD as well.
Like what?
One is crisaborole ointment, Eucrisa. This is a topical PDE4 inhibitor, similar in mechanism to the oral drug apremilast used for psoriasis. It's non-steroidal, used second line after steroids fail or aren't appropriate. Importantly, it's approved for patients as young as 3 months old.
A non-steroid option for babies. That sounds useful.
It is. Then there's dupilumab, Dupixent. This is a biologic, a monoclonal antibody given by injection. It works by blocking the signaling of 2 key interleukins involved in allergic inflammation, IL-4 and IL-13. This reduces a whole cascade of inflammatory responses. It's approved as a second-line treatment for moderate to severe AD in patients aged 6 months and older now, which was a recent expansion.
Another targeted biologic like in psoriasis.
Exactly. And finally, we have oral JAK inhibitors. JAK stands for Janus pinus. These are enzymes inside immune cells that transmit inflammatory signals. Drugs like upadacitinib, Rinvoq, and abrocitinib, Spinco, block these enzymes, effectively shutting down multiple inflammatory pathways from within the cell.
So like pulling the plug on the inflammation switchboard.
That's a good analogy. They are approved for adults, and upadacitinib also for adolescents 12+ read, with moderate to severe AD that's refractory, meaning it hasn't responded well to other systemic therapies.
Powerful stuff.
Yeah.
But I sense another warning coming.
You're right. These JAK inhibitors also carry a black box warning. This is due to increased risks of serious infections, mortality, malignancy, major adverse cardiovascular events like heart attack or stroke, and thrombosis, blood clots.
Wow. So again, very effective, but with significant potential risks requiring careful patient selection and monitoring.
Absolutely. It underscores the theme. Increasingly powerful and targeted therapies, but often with complex safety profiles that need careful management.
We have covered a lot of ground today, from the basic structure of the skin, all its jobs, to the really intricate ways these drugs work for common conditions like acne, psoriasis, atopic dermatitis. It's clear how complex skin health is.
It really is.
Yeah.
So what does this all mean for you, the listener? I think it shows that our understanding of why these conditions happen, the role of sebum, autoimmunity, specific inflammatory pathways, has really paved the way for smarter, more targeted treatments. But as we've seen, especially with things like the black box warnings, being informed about both the benefits and the potential risks is absolutely crucial. Knowledge really is power here.
Definitely. And it leaves you with something to think about, perhaps. As science keeps advancing, what's next? Beyond the drugs we talked about today,
Hmm.
could we see truly personalized medicine based on your unique genetic profile? Or maybe breakthroughs from studying the skin microbiome, all those tiny organisms living on us. Could those lead to even more tailored, maybe even safer ways to manage these chronic skin conditions down the road? It's certainly something to ponder.